Hello and welcome to the Complete Physio podcast. I'm here today with Dr. John Houghton and Mr. Jared Anflick, and we're going to be talking about Achilles tendinopathy, which can be a really tricky condition to get better, but hopefully we're going to get some excellent insights into how people can improve their symptoms. So let's first of all start with you, Jared. What is Achilles tendinopathy?
In the first instance, it's acute pain and swelling in the back of the ankle. And it's the simplest diagnosis we can make. There are many diagnoses within that, but in simple terms, it's pain and swelling in the back of the ankle.
And who gets Achilles tendon problems?
I mean, almost anyone. Elite athletes, sedentary people, anybody that plays any kind of sport. In this country, cricket, rugby, runners, everyday runners get a lot of Achilles tendinopathy.
And John, in your clinic, do you see people of all ages with this, or is it just a specific subgroup in?
Absolutely all ages. So I think it's important to understand, we get a lot of adolescent kids who start to get problems at the Achilles tendon, which it often isn't a tendon problem, it's a bone problem, but we go into that. And then in the younger age groups, there can be rheumatological problems going on. Obviously, we see a lot of athletes and runners where it's a mechanical problem. And as you get to older ages, more metabolic problems like menopause, obesity, problems with cholesterol, gout start to become important. So yeah, it's across the ages.
So already we've talked about quite simply what it is, but we've actually already talked about there's so many different things that can contribute to this. And probably there is so many different types of Achilles tendinopathies, because often it will be called Achilles tendinopathy, but that's very much an umbrella term, isn't it, for what is. So do you just want to talk, John, a little bit more about the sort of go into the specifics around the diagnostic side of it?
So I think probably there are some things that we like to rule out relatively early on. So the sorts of questions that we'll ask in our clinic are more about inflammatory conditions, and there's a bunch of things that can be associated with tendon inflammation. Might be people with psoriasis, for example, or inflammatory bowel disease, or inflammation in the spine. So those are very specific glitches in the immune system that cause inflammation at the tendon rather than the exercise that they're doing. So those are some of the simple things that we'll try and exclude early on. And then in the older age groups, it's more metabolic problems. So we see a lot of patients around the menopause who are still very active, who start to develop this problem. We see guys who cholesterol's a problem, or gout, or they've put on more weight and they're trying to get back into running. So I think that there are certain tests that we can do to help us understand what might be driving the tendon problem. And then in many people, there won't be any of those. Yeah. It will purely be a runner who's trained for a marathon, or, Jared, I don't know if you want to add in a little bit more about the athletic side of things.
Yeah, so the elite athletes, or just the general population athletes, they can be guys, as John said, training for the marathon, and their acute loads are very, very high and over a very short period of time. But then we also see, our differentials are things like, a small tear through the Achilles, pump bump, as one of our surgeons calls it, which is insertional tendinopathy. It could be a small linear tear. It could be bursitis. It could be even deep to the ankle, which could be an os trigonum or a tailordone, a stress response, those sorts of things. Paratendinopathy, where a lot of runners get that, where they get a squeaky sort of crepitus type pain on the back of the ankle. So there is a broad spectrum of diagnoses. Achilles tendinopathy is, as you said, absolutely, it is an umbrella term. And I think we need to drill into those so that we can provide the right treatment.
So if I was sitting at home watching this, you've both said lots of, medical terms. I'd be sitting there going, okay, I think I've got an Achilles tendinopathy. Where do I go from here? Like, not everybody can obviously come and see you, but what is the next stage for people to get that information and the right diagnosis? Where do you start, I suppose?
Yeah, I know.
Where do you start?
Where do you start? I mean, I think going to see a clinician that has a good idea about Achilles problems. GPs, as fantastic as they are, they're very overrun at the moment, and it can be quite difficult for them to really discern what that diagnosis is. So, a good physiotherapist is usually your first port of call. For them, it's going to be a matter of understanding or disseminating what actually is the cause, what's the diagnosis, and then the treatment follows quite quickly.
I think one of the problems is that, let's say you fall over and you break your leg, you can't run.
Yeah.
With Achilles tendinopathy, a lot of the time you can keep going. It just hurts, and people will they'll do a little bit less mileage, and it will get a bit better. Then they'll try and push forward again, and it will get a bit worse. So we often see people in the clinic maybe 18 months into the journey.
Very chronic.
It's a performance limiting disease.
Yeah.
So it's in the elites. Sorry to interrupt, John. In the elites, we see, those athletes, they just won't go for that ball that they might normally go for. They might not jump as high or sprint as fast, but they'll still get on the pitch and they'll still warm up. But it is a performance limiting disease. So they struggle. And as such, they let it linger 6 months, a year, 18 months. And, John and I have seen a patient that had Achilles tendinopathy for the better part of, I think it was like 25 or 30 years.
Yeah.
On and off every year.
But they can keep going, can't they?
Keep going.
It doesn't necessarily mean, I suppose, it's the right thing to do. It leads me on to actually a really good question I want to get onto, but I'm going to say it now, is should you rest a tendon? So if somebody's sitting at home with Achilles tendinopathy, they're like, oh, maybe I don't know if I should go for a run because it hurts. Should you rest it, or should you respect the pain a bit more?
So I think that's a great question. There's lots of different answers.
Yeah.
I think if it's the first time you've had it and it's relatively acute,
And by acute, you mean?
I mean, it's happened in the last 3 to 4 weeks, you've got a bit of swelling and stiffness in the morning, then that's a time where you should probably rest it from the load that aggravates, which is often running, jumping, for example. And those are the times when, at a very basic level, unless you've got no obvious contraindication to things like ibuprofen, that you can take a week of ibuprofen, see if it settles down, come off that activity, see if things do calm. I think if it then flares again, that's, as Jared says, that's when you probably need to see a professional who has some experience of managing Achilles tendinopathy. And in 90% of the cases, that's going to be a physiotherapist.
Yeah. And so if somebody goes to see a physio, there are lots of physios won't have any access to an X-ray or ultrasound or MRI. Do you need to have imaging of these tendons at that early stage, or when would you recommend, Jared?
I mean, not necessarily. It's an ideal scenario, but not everyone has access to that kind of imaging. I think, clinically, how long they've had it and what caused it. If a person has not done any physical activity and they wake up with posterior ankle pain, you wouldn't really lead to a diagnosis of potentially Achilles tendinopathy unless they've got an underlying, metabolic disease like gout or diabetes or something like that. But if they are a regular runner and they've upped their mileage, and that's probably a good reason why, changed their shoes, changed where they run, whether they've run on the same, pavement or whether they've done some soft sand running. But I think, in answer to your first question, should you rest a tendon? Yes, but really no. Tendons really need the load to get better, to heal. In the chronic state, we see people that have been resting for way too long. And that is the biggest problem that John and I often see, is the deconditioning effect of tendinopathy, whether it be Achilles or we also see patella. But with the Achilles, you see a loss of this calf mass and tone, which is a problem.
I think, you're saying a lot of physiotherapists, they might be single practitioner, they won't have access to imaging. I would be saying that there are some basic things that you can do in that early rest phase, maybe some medication, start some simple exercise. If people are not turning a corner in 4 to 6 weeks, then I think that should trigger somebody looking at that in more detail. And that's normally with some imaging.
Yeah. And what sort of imaging would you use in the first instance?
So again, it depends on resources, but I think that, traditionally X-rays have been used. In probably 8 out of 10 times, that's completely useless. It's not going to tell you what the problem is. MRI is expensive and harder to get hold of, and in my view, still gives you relatively limited information about the actual tendon. It helps exclude lots of the other problems that might behave like an Achilles problem, but probably ultrasound over the last 20 years has become the best first line because it's cheaper, it's more accessible, and you can get some good high-resolution images. And then on top of that, you've then got things like ultrasound tissue characterization, which I'm sure Jared will speak a lot more on. Those are the sort of subspecialist techniques that we're using in our clinic with our patients.
Yeah, I think that's really good. So just to recap, so generally speaking, around that 6-week mark, people would have tried a bit of rest, bit of medication, maybe a bit of loading, seen their physiotherapist. But certainly when you're getting to that maybe 6 to 8 or 4 to 6 week period, things aren't getting better, than imaging can have a role. And maybe Jared, what are you looking for specifically in your imaging? Talk a little bit around, what you might see and probably how that can change your management at that stage.
So for example, if someone has a paratendinopathy,
and just explain.
So that's the skin of the tendon is inflamed.
Yeah.
If we're seeing that, the management is really quite simple. And frankly, you can hit it with two things. One, anti-inflammatories, and two, just reduce your load. Maybe change your shoes. I know Nike a few years ago came out with a very high-backed running shoe, and a lot of people, athletes as well, but a lot of general population were getting paratendinopathy. But
there goes my Nike sponsorship for the podcast.
Unfortunately. But the shoes have gotten much better since then. That being said, other than paratendinopathy, there are intratendinous problems that people, experience. And, the classical one is I was running after my kid on the soft sand and I felt something. And those sorts of things require the imaging. And what we'll see is, a lot of structural change, an increase in the size of the tendon. So physios need to look and see, has that tendon, we call it fusiform, but has it gotten really thick? If it is really thick, then you have to suspect that things are obviously a bit more chronic, and then you have to start querying, well, what else is going on? And that's why the imaging is useful, because we can see why we've got these changes. And, another one is the plantaris-related mid-portion Achilles tendinopathy, which is the extra vestigial tendon that, 85% of the population have, that rubs along the inside of the tendon. Those things we can manage as well with different loading program.
Yeah,
potentially medication, and with John we do injections and things like that.
Yeah. So, and if anybody Googles Achilles tendinopathy, they're generally going to get somebody on YouTube showing them a couple of exercises. And I suppose what you're alluding to there is that one treatment, need a specific diagnosis to do a specific treatment. Whereas a lot of the time, what we find is that, and generally speaking, people will start quite a generic program. The good thing with that, probably, because we don't see them, 80% of people have already got better.
Yeah.
But if we're saying that there's different types of diagnoses with Achilles, which we are, then obviously that can lead on to different types of treatments. So do you want to, John, give us an idea of what treatments you guys use and in what situation?
Yeah, so I think that, on the whole, we kind of split the treatments probably into 3 or 4 areas. So, the specific exercises, which I'll kind of leave Jared to speak about. In terms of medication, then there are some studies that have shown that more strong medication than ibuprofen can be helpful. So we've utilized a lot of the stronger prescription anti-inflammatories. I tend to use something called etorecoxib. It's one of the newer brands that are a bit kinder on the tummy. And we also use something called doxycycline, which is an antibiotic, which we might use for 3 or 4 weeks because it helps reduce tendon inflammation and helps the sort of breakdown of the tendon. We also recommend some supplements also. So sort of omega-3s, specifically the EPAs, tend to show a good benefit in their anti-inflammatory properties. So we might use medication to start with. In terms of injection therapy, it depends on what we think is driving it. And Jared alluded to this earlier. Is there a little tear in the tendon, or is it this extra little tendon that's rubbing on the Achilles? And the guy that we saw who'd had pain for 25 years, we both knew what we were going to see when we put the imaging out. He has a big plantaris tendon rubbing on his Achilles. So each time he overloaded, that would stir it up. So if that's the case, we sometimes use a lubricant injection between the plantaris and the Achilles to reduce that inflammation. If there's a tear, we might consider something like a blood injection or PRP, which, I'm sure some of your listeners will have heard about, but essentially taking some of the body's blood, getting rid of the red blood cells, you're left with the plasma, which has all the kind of growth factors in, and then injecting that into that small tear that's in the tendon. It's not going to cure a complete total rupture, but the little tears, it will do. And I think this is one of the problems that we as doctors try and design studies to say what works for the Achilles tendon.
Which physios do studies as well.
I was talking about the physios, your doctor.
Okay.
With your PhD. So, but when we design studies, looking at medical interventions, it normally lumps everybody together. And so therefore, that's why I think we're still a little bit in the dark as to what works, what doesn't, because we're not choosing the right people specifically for those stuff.
Or the right intervention for that diagnosis. And that's really key. And I think the media hasn't potentially helped the situation when you see ex-footballer getting a PRP injection and magically he's on the field in 3 weeks' time. That doesn't really help, mainly because we don't know what his diagnosis is. And one intervention doesn't necessarily work for all diagnoses within that framework of Achilles tendon.
And I think the thing that we struggle with is because people, like you said, because people can continue to play, continue to run, that doesn't mean they're not necessarily damaging it, but they're not necessarily making it better. And I think it's like that crescendo pain, isn't it? Where they can keep going, and at some point it's really bad. And obviously at that point is when we see them, and that could be a few years down the line. So any intervention can be a little bit slower to improve,
exactly.
A bit trickier. So if I was sitting at home, I've got Achilles tendinopathy, I've tried a few exercises. Why do you think, and I think the research, Jared will correct me, but the research is in terms of exercise therapy, only about 50 to 60% of people improve with exercise therapy, where obviously it's the thing that we all try first. Why do you think, Jared, that maybe not as many people as we would expect improve with exercise therapy and rehabilitation?
It's a great question. And I think I can only take it back to some intratendinous load studies when we understand what the Achilles tendon has to endure when it's running. And so if you ran at 6 meters per second, you know, the tendon intratendinous loads are 10.5 times body weight. And so if we understand that running has high loads multiplied by every single foot strike, we would measure a 5K run in tons, not in kilos. That being said, I think a lot of the older studies that were done in exercise therapy for Achilles tendinopathy were done with body weight. And unfortunately, one body weight, the intratendinous load is not one body weight, but just doing your own body weight up and down is generally not enough to stimulate the tendon to want to be better, to get better and to heal. So we know there are a few things that are really important in the management of tendinopathy. And one is the magnitude of the load. 2 is the frequency in which you do that load. 3 is the duration of the contraction. So going up and down super quickly potentially is not that useful. And then potentially periodizing it. So those 4 sort of really important modules how we help non-elites and elite athletes get better. And so knowing all of that, how would someone at home watching this podcast get better? You know, I would encourage them to do a seated calf raise, because soleus takes up 70 to 80% of the posterior.
So that's when you do a calf raise.
Seated calf raise. Yeah, seated calf raise. And I'd start with a bit of volume. And the reason why volume, and some would argue, well, you don't need to do volume. There's some really good evidence to say that if you want to improve or increase the amount of collagen turnover within the tendon, you need a bit of volume to start with. And also it's quite conditioning for the calf. Yeah. You don't want someone that hasn't done any calf loading doing 6 reps, 6 sets, as heavy as 6 reps and 6 sets should be, because they get very sore, and most likely their tendon will get sore. So I usually start with a bit of volume, and that's 4 sets of 15 reps. And then a standing calf raise. But herein lies a little bit of a predicament. So the original loading programs were off a step. And the issue that you would have is if you have insertional tendinopathy, so down at the bone, or you have plantaris related, which is along the medial side, if you drop down past the horizontal on a step, you'll get really sore. And generally, those are the patients that don't really respond particularly well to loading. So part of it is modifying it. So I would say if you were at home and you had Achilles pain, I would say as safe as houses would be bent knee calf raise and a standing calf raise from the flat, but using a weight, some kind of external weight.
And so I'm a very impatient man. That was what I was smiling in. I was trying to get my question in. But how, you're not going to want to answer this. You're going to say it depends, okay? But you've got to answer it. You're not allowed to say it depends. How long do people give it before they say, but it hasn't helped? I've tried that. Like, how long do you say to your patients, you've got to do this for this long?
So it depends. But I will say this.
Yes.
A lot of the research is done over a 12-week period.
Yeah.
We know that that's not long enough, but all good research, which is usually an RCT, It's very hard to run an RCT greater than 12
So an
weeks.
RCT
Randomized controlled trial. So it's good evidence, high level evidence. And one of the reasons is it's very expensive to run an RCT. Doing that kind of research costs, whether it be the NHS or the hospital or the organisation doing it, costs them a lot of money. So 12 weeks is what the minimum time frame would be. But you should start to see an improvement in your symptoms 6 to 8 to 10 weeks. Would you agree?
I think that's fair. And I guess it depends. We're talking about the person who's sitting at home who's had their first onset of Achilles pains.
Yeah.
And they've had their symptoms for 4 weeks. Yeah. Absolutely, within 6 to 8 weeks, we expect to see a really good turnaround in their symptoms. For somebody who's had 4 years of pain and multiple risk factors,
and multiple episodes,
then you've got to persuade them that it's a longer term journey and that it might be that they're still going to be doing their exercises twice a week in a year or forever if they want to continue doing their sport that loads the Achilles. So it is a little bit variable, but we would like to see an improvement definitely by 8 weeks.
Yeah. And let's say they don't get an improvement at 8 weeks. Where do you go from there? I assume you're going to check the diagnosis is right. But, there is a lot out there about injections, shockwave therapy. I'd be quite interested in either of yours opinion on these adjuncts to treatment and what do you think the effectiveness is from your experience?
Yeah, so I used a lot of shockwave therapy, probably started 20 years ago. I probably use it less now, but I think there are still some certain situations where it can be very helpful. For example, a bone spur on the heel where there might be a bit of calcification around the tendon.
So that's more the insertion
down right on the heel bone rather than the sort of the stringy part in the middle. Yeah. So I think I did used to use it on the stringy part in the middle, but as we've learned more about what might be causing it, I think there are better treatments. Yeah. And also I'd be much wary if there's a small tear in the tendon. I now would be really cautious. I wouldn't want that to be shockwave because it could potentially get worse. I think shockwave is useful in some patients. What it does is probably more around pain than recovery of tendon tissue. Sure. So if you can reduce the pain, then they can load more and they can get a better process going to change the actual tendon structure, which is where the exercise comes in.
Yeah.
So most of what I do with medication is to reduce pain to enable people to do the exercise and do it to a higher degree and a higher intensity sooner.
Yeah. So I want to talk about injections, and specifically lots of people maybe 10 years ago or even still today are having steroid injections for their Achilles, and people are looking for that quick miracle cure, aren't they? Yeah. Where are we from an injection point of view, and what's your thoughts around that at the moment?
And I think that's the problem, the miracle cure, because there are definitely people who will be watching this and say, I had a steroid injection and I was fine.
Yeah.
But it needs to come with a warning.
Yeah.
And now, we just don't think about injecting steroid around the tendon.
I think we've probably done 2 in 7 years, and that wasn't even into the tendon.
So the worry is that the steroid will reduce pain quite quickly, but what it does is it also gets in the way of tendon healing, and it may make the tendon a little softer. It may make a tear a little bit bigger. So there is always that increased risk of rupture. And also other side effects. I've seen some bad side effects where it sort of dissolves some of the fat around the Achilles or changes the color in the skin around it. And those are the things why we don't do that so often now. It will make it feel better for 4 weeks, but in the long term, it's not doing you any favors.
No, absolutely. Jared, maybe if we just go on to what you do from an injection point, you've talked about PRP and hyaluronic acid or some sort of lubricant for the plantaris. I suppose what I want to know is how effective do you think they are? Because there is, different approaches, there's different opinions, definitely, but I know you guys use it you probably see more Achilles than anybody else. So, if you had an Achilles problem, Jared, would you go for an injection option?
I think if it's the right diagnosis. So if I had a which I do have on my right side, a plantaris-related mid-portion problem, I would go for a HA injection. And I actually might get John to do it as well. I'm having already had one today, hitting into my ankle. But I definitely would, because
tell us about why you're comfortable with HA, so this hyaluronic acid
well,
specifically.
because HA occurs naturally within the IFM, which is the intravesicular matrix where the fibrils are bundled together. And that's kind of the gel that makes the tendon quite springy. So I'm not introducing it completely, although it's a synthetic, a completely foreign material to the tendon. And we're not doing into the tendon. That's the other thing. We're doing around the tendon. And I think that makes a big difference. You know, the PRPs that we often do, we're doing it because there is a tear in there and we're trying to stimulate a repair. As John alluded to before, or said before, one of the biggest issues with PRP is that we group everyone together with Achilles problems and we do a PRP. And potentially, if we could tease out those people that had a linear tear, those people that had plantaris related, those that had a paratendinopathy, we don't treat shoulder pain all the same. We don't treat tummy pain all the same. It could be liver, kidney, it could be anything. So I think in the way that John and I run the clinic is the treatment is designed based on what the diagnosis is. So coming back to your question, if I had a linear tear in my Achilles, I probably would go for a PRP in the short term because I think we get good results with it.
And how long does it take for that sort of for injection therapy to help generally? Is it the immediate miracle cure or
it depends.
Well, I mean, for the PRP, for example, we inject and we put them in a boot.
Sure.
Because we created an inflammatory storm and we want a little bit of a scar to form and we want some collagen turnover, and then we load them. And the loading is probably just as important, if not more important, than the injection. A hyaluronic acid injection, I mean, we've done some in some elite footballers where they get back, very quickly.
Yeah.
But the diagnosis has to be very, very clear and spot on, and then all parties involved.
What you always find is when somebody's had an injection, they're very compliant with their exercises. They're very willing to do whatever you say. And I think that helps as well, doesn't it? Or sometimes it slows them down a little bit and gives them a bit of time to recover. So I really want to talk to you about surgery. Now, I know neither of you are surgeons, but you work very closely with lots of surgeons that do an operation for Achilles. Now, we're not talking about Achilles ruptures here. Yes, you might be able to get that operated on. But is there a role, I'll start with you, John, is there a role for surgery in a bog standard or an Achilles tendinopathy? Because people get to that point where they are considering it.
So I think the first thing to say is that in the vast majority of Achilles tendon problems, they do not need surgery.
Yeah.
So, if we look across the whole population, it's probably less than a couple of percent of actual episodes of Achilles tendon pain.
But that might be higher in elites?
Maybe, yes.
In higher level, higher functioning.
With elites, the goals are always a little bit different and the time frames are a little bit different. Yeah. So I would say that absolutely, yes, we would encourage surgery if we feel that we've done everything conservatively that we can, or that we feel it's not something that is going to respond to the tricks and the tools that we got in our box.
Yeah.
So for the plantaris problems, we'll often start with the lubricant injection, do a round of loading. And I think maybe in the past we repeat that cycle. I think now we would sooner say to them, look, if you're frustrated, then maybe surgery is the right thing. You're still going to have to do your homework, you're still going to have to do your exercises, but to stop this keep coming back, if it's the second time it's happened or the third, then those are the instances where we're much more amenable to talking to our surgeons about what happens next.
Yeah. Jared, have you got any?
I would agree wholeheartedly. I think it depends on the person, how long they've had it.
Yeah.
The person that had 27 years of Achilles pain, when we saw him, we tried one injection, and then beyond that, it was, listen, you've got an enormous, I think it was 5 or 6 mil size plantaris that had hypertrophied, adhered to the side or stuck down to the side of the tendon. We weren't going to be able to tease off, or John wasn't going to be able to tease it off with a needle. So they do need surgery, and I think the more and more patients that we see, unfortunately, it's that clinician opinion, and it does become biased. I'm not going to say we are entirely impartial, but I think with the imaging that we have and the patient's clinical presentation, we can have a very, very good idea about which kind of patients or who will respond to loading and who will really just needs to go to the surgeon and get a plantarisectomy, removal of that plantaris, and off they go. You know, I saw a well-known rugby player some years ago, and, you know, I saw him with his physio. They'd done all the right kind of loading. I couldn't fault them for it. And in the end, you know, I said, I can't help you. This is what I'd like you to do. I want you to get a plantar osteotomy. I want you to go and see one of our surgeons who removed it, did a fantastic job, Mr. Jones. And the player played in the World Cup recently. So, you know, I think you have to pick those patients, and that comes with someone that sees a lot of tendons like John.
Yeah, I think, and you said, and I.
It's your choice of surgeon as well. You have to be seeing someone who understands what's going on, and also is going to do the least amount possible to get the result, because tendon tissue is, you know, it's precious. And so if you can maintain as much normal tendon, good tendon as possible you can, then the outcomes tend to be better.
And I think, you know, the medial gastroc release or the fenestration of the Achilles tendon, which used to happen 10, 15 years ago, is just, there's no place for it anymore, because we know how important the calf muscle is at generating stiffness, and how important the tendon is, the health of the overall tendon. And, you know, just fenestrating or, you know, doing incisions to the Achilles tendon is just not helpful. So our surgeons are, you know, they understand the imaging that we do, and they're very amenable to us coming in and, you know, this is what we see, this is the clinical picture, this is the imaging, and we sometimes need to explain it, but this is what we see, and this is where, you know, would be a great place to start, or this is kind of the extent of the injury.
I think it's so important to see the clinicians that have a lot of experience. You know, lots of us will treat lots of areas, but we definitely have more experience in certain areas. And I think certainly when people are struggling with pain, it's really important that they do see people that can understand and look into their problem in a little bit more detail. If I did own a Ferrari, which I don't, I would take it to a Ferrari mechanic. I wouldn't take it to Quick Fit. Does that at all work as an analogy? Maybe for an elite sports person.
Yeah, I mean, I think, listen, in elite sport, they will shop around, and often you won't be the only opinion that they're having. But I guess, they have more resource on the whole.
Yeah.
And they need answers quite quickly, because they need their athlete back performing for many, many reasons normally.
Perfect. Well, thank you very much for your time. I hope your ankle does get better, Jared. Thanks for coming.
Thank you.